Hello everyone, my name is Dr. Sikandar and today we will discuss about the anatomy of pleura. Let's start. What is pleura? Pleura is a serous membrane, very important. It is a serous membrane that covers the lung parenchyma, the mediastinum, the diaphragm and the rib cage. It is divided into visceral and parietal pleura. Visceral pleura covers lung parenchyma not only at its point of contact with chest wall, diaphragm, and mediastinum, but also in interlobar fissures. So, visceral pleura covers the lung in interlobar fissures also. Then they are telling like parietal pleura lines the inside of the thoracic cavities. It is subdivided into costal along the ribs, mediastinal along mediastinum part, and the diaphragmatic parietal pleura. The visceral and parietal pleura meet at lung root at the pulmonary hilum, and mediastinal pleura is swept laterally onto the root of the lung. Posterior to the lung root, pleura is carried downward as a thin double fold, which is known as pulmonary ligament. So this is the pulmonary ligament, and this is the root of this is the hilum where like this lung root is there, and like around that slightly posteriorly it is coming downwards. So this is double fold, thin double fold, which is known as pulmonary ligament. Then they are telling a film of fluid, pleural fluid is normally present between parietal and visceral pleura. This thin layer of fluid acts as lubricant and allow the visceral pleura to slide against the parietal pleura, lining the thoracic cavity obviously during respiratory movements. The space between two layers of pleura is pleural space. Mediastinum completely separate. Right to left pleural space means right and left pleural space are separated by diaphragm, mediastinum. They are not connected to each other. Only a thin layer of fluid is normally present in this space, so it is potential space. Potential space is a space where two layers opposed to each other, and like there is minimal fluid is there in between. So like they are telling, so it is a potential space rather than an actual one. Many diseases are associated with increased amount of pleural fluid. So now we will discuss about the embryology of pleura and pleural space. So they are telling like cephalic portion, or they are telling like cephalic portion of coelomic cavity become the pericardium and communicate bilaterally with pleural canals, which in turn communicate with the peritoneal canal. So they are telling there is a pericardial cavity which used to connect with these pleural cavity, and like these pleural cavities are connected with this like parietal cavities. So yeah. After that, they are telling that with development, the coelomic cavity become divided onto pericardium, pleural cavities, and peritoneal cavities through the development of three sets of partitions. So, what are those partitions? They are telling the septum transversum, which serve as an early partial diaphragm, the pericardial membrane, which divide the pericardium and the pleural cavity, and the pleuroperitoneal membrane, which unite the septum transversum to complete the partition between each pleural cavity and the peritoneal cavity. So this newly formed pleural cavity is fully lined with mesothelial membrane, which is known as pleura. When the primordial bronchial bud first appear, they and the trachea lie in a median mass of mesenchyme, and they are telling like cranial and dorsal to the peritoneal cavity. This is lying cranial and dorsal to the peritoneal cavity obviously, and this mass is known as mediastinum, and it separates the two pleural cavities. In humans, there is no communication normally exists between two pleural cavities. As the growing primordial lung bud bulge into the right and left pleural cavity, they carry with them a covering of lining which is known as mesothelium, and which later makes visceral pleura. As the separate lobe evolve, they retain their mesothelial covering. This covering becomes visceral pleura in the fissures, and the lining mesothelium of the pleural cavity becomes the parietal pleura. So this lining mesothelium of the pleural cavity is parietal pleura, while like these like they are telling like separate lobes when evolve, they retain the mesothelial covering which becomes visceral pleura. After they are talking like parietal pleura over the ribs and intercostal space is composed of loose, irregular connective tissue, which is covered by a single layer of mesothelial cells. So parietal pleura is a very loose, irregular, and made of connective tissue, and it is a single layer of mesothelial cells. Within the pleura, there are blood vessels, many capillaries. So, like they are telling, mainly capillaries. In blood vessels, also only capillaries exist, and like mainly capillaries exist, and lymphatic lacunae are there. The lacunae are specialized initial lymphatics shaped like flat cistern and are located over the intercostal spaces, mainly over the intercostal spaces. There are these lacunae used to be there, and they are telling the mean thickness of parietal pleura is 20 to 25 micrometer, whereas the distance from the microvessel to the pleural space is 10 to 12 micrometer. Deeper to the parietal pleura, there is a endothoracic fascia. This continuous band of dense irregular connective tissue. It is not loose like parietal pleura. This is dense irregular connective tissue composed mainly of collagen and elastin and cover the rib intercostal space and varies in thickness from 75 to 150 micrometer. So like this is more thicker than parietal pleura. So this dense band is known as endothoracic fascia. After that, they are telling the anatomy of visceral pleura differ markedly from that of the parietal pleura. And humans have a thick visceral pleura. Very, very important. So like visceral pleura and parietal pleura are very different things, and humans have thick visceral pleura. The distinction between lung with a thick or thin visceral pleura is important physiologically because the blood supply is dependent on the thickness of this visceral pleura. So they are telling like in animals with thick visceral pleura, like humans, the predominant source of blood supply is systemic circulation. Very, very important. In those with thin pleura, the predominant blood supply is pulmonary circulation. So as we have discussed, like humans used to have thick visceral pleura, so they used to be supplied by systemic circulation. Histologically, a thick visceral pleura is composed of two layers. First is mesothelium and second is connective tissue. Now they are telling like blood, lymph vessels, nerves are located in the connective tissue. Animals with a thick visceral pleura have a layer of dense connective tissue of varying thickness interposed between the mesothelium and blood vessels. Very, very important. So like this dense connective tissue used to be interposed between mesothelium and blood vessels. In sheep, the visceral pleura ranges in thickness from 25 to 83 micrometer as compared to 10 to 25 micrometer of the parietal pleura. Means like visceral pleura is thicker than parietal pleura, and the distance from the microvessel to the pleural space range from 18 to 56 micrometer, which is like more as compared with parietal pleura. So like thickness and distance, both things are more with respect to visceral pleura. Then they are talking like connective tissue layer in the visceral pleura has two important functions. It contributes to elastic recoil of lung, which is important in expelling air from the lungs. So elastic recoil of lung is very important. And then they are telling it restricts the volume to which the lung can inflated, thereby protecting it. So it like also protect the lung by because it used to prevent the inflation of the lung. Then they are telling that in the visceral pleura, fiber of the elastic and collagenous system are clearly interdependent element. Collagenous fibers are interwoven in a pleated structure that closely resemble the osier of wicker basket like this. This is like a basket, which is and like collagenous fibers arrangement is like this, that only, and suggesting that collagen fibers allow the lung volume to increase up to a maximal stretching point. Then comes elastic recoil pressure of the lung, which originates from the elastic network, which return to its resting position when respiratory pressures are negligible. So like it used to like allow to recoil the lung, which is known as elastic recoil pressure. Both the visceral and parietal pleura are lined with a single layer of flat mesothelial cells. So these flat mesothelial cells were very important, and these are lined as a single layer. These Mesothelial cells ranges in size like 6 to 12 micrometer in the diameter, which is with scanning electron microscopy, the pleural surface is found to be either flattened or bumpy. So if we used to do like electron microscopy of these mesothelial cells, then we can see like pleural surface used to be like either flat or it used to be like bumpy like this, or it could be like this. The bumpy areas include most of the visceral pleura and the portion of the parietal pleura. These areas appear to result from lack of rigidity of the underlying structure. Means like underlying structure is not that rigid, so it used to get bumped out. So this is and this is because of the visceral pleura. And like here we can see these bumpy areas are because of this visceral pleura, and underlying thing used to be non-rigid. And here they are telling like A is bumpy pleural surface with cellular border are irregularly depressed. Note that number of microvilli present on each cell used to variable. And this second diagram is like flattened pleural surface with indistinct cell boundaries and sparse microvilli. Scanning electron microscopy also demonstrates that microvilli are present diffusely over the entire pleural surface, but the distribution of the microvilli is irregular. This is not like regular distribution. The density of microvilli ranges from a few to more than 600 per 100 micrometer square with a mean of approximately 300. So like these microvilli used to be like 600 around, like maximum it could get like 600, and they, like mean is like 300, like they used to be 300 per cell. The microvilli, not per cell, like per 100 micrometer square. The microvilli are most numerous on the inferior part of the visceral pleura, very very important, and the anterior and inferior mediastinum on the parietal pleura. So like inferior part of the this, like this is the lung of our body. Then like visceral pleura is like inferior part of visceral pleura is this part. And like this, if this is like parietal pleura, so they are telling like mediastinal, like anterior and inferior, like this part and this part of mediastinum used to get highest number of microvilli. At corresponding regions in the thoracic cavity, more microvilli are present on the visceral pleura, like visceral pleura having more than parietal pleura. Than the parietal pleura. The microvilli are approximately 0.1 micrometer in diameter, and their length vary from zero point 0.5 to 3 micrometer. Then they are telling exact function of these numerous microvilli is yet to be defined. Like it is not known. At one time, it was believed that their presence increased the capacity of visceral pleura to absorb pleural fluid. It was believed, but it is incorrect. It is incorrect, very important, because recent observations have indicated that the visceral pleura play a limited role in the absorption of pleural fluid. Very, very important. So it play very limited role. It is now thought that most important function of the microvilli is to enhance glycoprotein. So it used to release the glycoprotein that are rich in high hyaluronic acid. Hyaluronic acid. These used to release, like these microvilli used to release glycoproteins which are rich in high hyaluronic acid, especially in the lower thorax. That decreases the friction between the lung and the chest wall. Very, very important. So it used to release high hyaluronic acid by releasing from the microvilli. So now they are telling the mesothelial layer is very fragile. So this mesothelial layer is very fragile. A thoracotomy in patient without clinical pleural disease, denudation. Focal denudation means like it used to get out of the mesothelial cell is very common. When the normal layer of mesothelial cell lining, the pleura is disrupted, the defect is repaired through the mitosis and migration of these mesothelial cells. When irritated, they retract but retain continuity with adjacent cell by projections called as cellular bridges. Mesothelial cells are frequently dislodged from the pleural surfaces and are thereby free in the pleural fluid. When free in the pleural fluid, the cells become round or oval in the shape. So these mesothelial cells can dislodge from pleura, and they used to come freely in the pleural fluid, and their cytoplasm is rich in organelles. When this state, they may be transformed into the macrophages, which is capable of phagocytosis and erythrophagocytosis. Such transformed cells frequently have vacuoles in their cytoplasm. Very, very important. Not all the macrophages in the pleural fluid evolve from the mesothelial cells. Some definitely evolve from the peripheral blood mononuclear cells. So they are telling like macrophage always do not like used to be formed from these like mesothelial cells, but they can be evolved from peripheral blood mononuclear cells also, and some may evolve from the alveolar macrophages also. An immunological role has been suggested for the macrophages derived from the mesothelial cells, so they do have immunological role. Now we will come on mesothelial cells. So what about the mesothelial cells? Mesothelial cells form a monolayer of specialized pavement-like cells that line the pleural surfaces. So this is always a monolayer of specialized pavement-like cells, like this kind of cells. These are like pavement-like cells. The mesothelial cells are active cells and they are sensitive and responsive to various stimuli. So like if there is some stimuli comes, then they used to respond to that stimuli. The mesothelial cells that line the pleural cavity and those that line the other body cavities have no recognizable cytological difference. So they are like same. The cytoplasm always contain a moderate to abundant amount of organelles, including mitochondria, rough and smooth endoplasmic reticulum, polyribosome, intermediate fibrils, Golgi apparatus, and the glycogen granules, suggesting that mesothelial cells is metabolically active cell. Very, very important. So this is a metabolically active cell. Mesothelial cell is a metabolically active cell. The function of mesothelial cell. The mesothelium is now recognized as a dynamic cellular membrane with many important functions. So what are the functions? These include transport and movement of the fluid and the particulate matter across the pleural surfaces, leukocyte migration in response to inflammatory mediators, synthesis of cytokine, growth factors, and the extracellular matrix protein, release of factor to promote both the deposition and the clearance of fibrin, and antigen presentation. So these are the function of mesothelial cells. What are those functions? I will tell them again. They are telling the transport and the movement of the fluid and particulate matter across the pleural surface, leukocyte migration in response to inflammatory mediators, synthesis of cytokine, growth factors, and extracellular matrix proteins, release of factors to promote both deposition and clearance of fibrin, and antigen presentation. Mesothelial regeneration involves migration of cells from the wound edge and attachment and incorporation of free boating mesothelial cells from the pleural fluid onto the denuded pleural surface. What is their role in pleurodesis? There is strong evidence that mesothelial cells can convert to myofibroblast. Incubation of peritoneal mesothelial cells with TGF3 and reported that mesothelial cells took on the characteristic mesothelial cell took on the characteristic of myofibroblast phenotype. So they are telling if we will incubate these mesothelial cells with TGF transforming growth factor 3, then they can take the form of myofibroblastic phenotype. We have observed that the incubation of human mesothelial cells with TGF3 result in their morphological transformation to cells that look like fibroblasts. So they used to convert into the fibroblasts. It has been shown that the intrapleural administration of TGF3 results in an excellent pleurodesis, and the morphological changes induced by TGF3 referred to here may be important in producing pleurodesis. Very, very important. So this incubation will produce pleurodesis by transforming these mesothelial cells into the fibroblast. Very, very important. So we can use them, these transforming growth factors, in producing pleurodesis. In cell culture, mesothelial cells have been shown to produce type 1, type 2, type 4 collagens, elastin, fibronectin, laminin, and to tend to express intermediate filaments typical of both epithelial cells and the fibroblasts. Mesothelial cells also express procoagulant activity because of a tissue factor that bind factor 7 at the cell surface. So it used to like produce a procoagulant activity, very very important. So this is a procoagulant activity. This is the cell which is having procoagulant, like increase the coagulation because of a tissue factor that bind to factor 7 at the cell surface. Mesothelial cells have also been demonstrated to produce nitric oxide and TGF3 as well as many other cytokines. Now they are talking about the physiochemical factors. Normally, a small amount of pleural fluid is present in the pleural space. Mean amount of fluid in the right pleural space in a normal individual is 8.4 plus minus 4.3 ml. Like it is around 10 ml. Normally, the volume of fluid in the right and left pleural space is quite similar. Expressed per kilogram of body mass, the total pleural volume in normal non-smoking humans is 0.26 plus minus 0.1 ml per kg. Now they are telling like the small amount of residual pleural fluid appear to be distributed relatively evenly throughout the pleural space. Therefore, the pleural fluid behave as a continuous system. The average arithmetic mean width of the pleural space was slightly more narrow near the top than at the bottom. Pleural space width in the most dependent recesses, such as the costodiaphragmatic recess, reached 1 to 2 mm. So, like they are telling this, width of pleural space is more in the bottom part, very very important, and it is narrower in top part. They were unable to find any contact between visceral and parietal pleura because the microvilli of the mesothelial cells in the visceral and parietal pleura do not interdigitate. The friction forces between the lung and chest wall were very low. So like they were very separate in like bottom part. So this is the thing they are talking here. Now they are telling the mean white blood cell count was around like 1700. It was 1716 cell per mm square mm cube, and the mean red blood cell is 700 cell per mm cube. These numbers are similar to those recorded in other animals. In humans, approximately 75% of the cells in pleural fluid were macrophages and 25% are lymphocytes, with mesothelial cell, neutrophil, and eosinophils accounting for less than 2%. So other cells are less than 2%, but lymphocytes are 25%, and like uh, macrophage were 75%. In the variance in the different count in these series may be related to strains used and definition of mesothelial cells and macrophages. Like what is the exact definition of mesothelial cell and macrophage? Like it used to depend on these things also. Like what will the differential count? Then comes to then we comes to protein. A small amount of protein is normally present in the pleural fluid. In the rabbit, the protein concentration was average 1.33 gram per deciliter, whereas in the dogs, it averages 1.06 gram per deciliter. The mean oncotic pressure in the pleural fluid is 4.8 centimeter of H2O. In rabbits, it was 3.2 in rabbits it was 4.8, and in dogs it was around 3.2 centimeter of H2O. This was the oncotic pressure. Protein electrophoresis demonstrates that the electrophoretic pattern of the pleural fluid is similar to that of corresponding serum. Very very important. Except that low molecular weight proteins such as albumin are present in relatively greater quantities in the pleural fluid. So like they are telling low molecular weight protein like albumin was very high in the pleural fluid. Not very high, but relatively greater in the pleural fluid. Then they are talking about the electrolytes. Interestingly, the ionic concentration in the pleural fluid differ significantly from those in the serum. So like what is the ionic profile? So they are telling like pleural fluid bicarbonate concentration pleural fluid, bicarbonate concentration is increased by 20 to 25% relative to that in the plasma, whereas the major cation like sodium is reduced by 3 to 5% and the major anion is reduced by 6 to 9%. So major cation is reduced by 3 to 5% and major anion like chloride is reduced by 6 to 9%, while bicarbonate used to get high like 20 to 25%. The concentration of potassium and glucose is like almost similar to that of plasma. The gradient of bicarbonate persists when animal are given in carbonic anhydrous inhibitor. Like if we used to give carbonic anhydrous inhibitor, still like bicarbonate level used to be high. When unilateral artificial pleural effusion of distal water were produced in the rat, electrolyte equilibrium between the pleural fluid and the venous plasma was reached approximately within 40 minutes, but the foregoing gradient persists. After that, those were persist. Then they are talking like pleural fluid pressure of CO2 is approximately the same as the plasma PCO2. Accordingly, in the view of the elevated pleural fluid bicarbonate, the pleural fluid is alkaline because bicarbonate used to be high in the pleural fluid with respect to the plasma pH. So they are telling with respect to plasma, it used to be alkaline. These gradient of the electrolyte suggest that an active process is evolved in pleural fluid formation. So actively it is forming. Then they are talking about the blood supply of the pleura. The parietal pleura receive its blood supply from the systemic capillaries. Very, very important. Small branches of intercostal arteries supply the costal pleura, whereas the mediastinal pleura is principally supplied by pericardiophrenic artery. So like pericardiophrenic artery used to supply the mediastinal this parietal pleura, while intercostal arteries used to supply the costal pleura. The diaphragmatic parietal pleura is supplied by the superior phrenic and musculophrenic arteries. Very, very important. So this is the blood supply of parietal pleura. Then they are talking about the venous drainage. The venous drainage of parietal pleura is primarily by the intercostal veins, which empty into the inferior vena cava or the brachiocephalic trunk. The venous drainage of diaphragm is either caudally into the inferior vena cava through the inferior phrenic vein or cranially into superior vena cava through the superior phrenic vein. So it could be in either way. Then they are telling that the blood supply to the visceral pleura is depend on whether the animal has a thick or thin pleura. Very important. We have talked this earlier. Like blood supply of visceral pleura depend on its thickness. So in humans it used to be thick. So they are telling like with a thin pleura originate from the like blood supply used to originate from the pulmonary circulation, whereas the blood supply in animal with thick pleura like humans originate from the systemic circulation through the bronchial artery. So in humans, visceral pleura used to get supplied by bronchial arteries. Humans have thick visceral pleura, which is probably why it is supplied by the bronchial artery. But there is still controversy. All investigator agrees that bronchial artery supply most of the visceral pleura facing the mediastinum, the pleura covering the interlobular surfaces and the part of diaphragmatic surface. The blood supply of remaining portion like of the visceral pleura is less understood and it is thought to be like supplied somewhere in by the pulmonary artery. Like in few parts, only in few parts it used to get supplied by the pulmonary artery. Rest in all the parts it used to supplied by bronchial artery. Visceral pleura is supplied by the bronchial artery while parietal pleura is supplied by the systemic circulation. Got it. Now comes like venous drainage of the visceral pleura. It is through the pulmonary veins. So venous drainage is fixed and it is by the pulmonary veins. Then we comes to like lymphatics. The lymphatic plexus in the costal pleura are mainly confined to the intercostal spaces and are absent or minimal over the ribs. So they are not over the ribs, they are minimal over the ribs and they are mostly in the intercostal spaces. The lymphatic vessels of the costal pleura drains ventrally toward nodes along the internal thoracic artery. and dorsally toward the internal intercostal lymph node near the head of the ribs. Okay. Then they are telling like the lymphatic vessels of the mediastinal pleura pass to the tracheobronchial and mediastinal nodes. The lymphatic vessels of mediastinal pleura passes to the tracheobronchial and mediastinal nodes, whereas the lymphatic vessels of the diaphragmatic pleura pass to the parasternal, middle phrenic, and posterior mediastinal nodes. When quantum dot with a diameter of 15 micrometer are injected into the pleural space of pigs, they are first visualized in superior mediastinal node. We have already discussed these things. Then they are telling that lymphatic vessels in the parietal pleura are in communication with the pleural space by means of stomach that ranges in diameter from 2 to 6 micrometer. When nitric oxide concentration are increased, the stroma used to get enlarged. In one study, the average density of the stoma was 121 per mm cube. These stomas have round or slit-like shape and are found mostly on the mediastinal pleura and on the intercostal surface, especially in the depressed areas just inferior to the ribs in the lower thorax. There are more stomas in area where mesothelial cells are cuboid rather than flat. So like wherever these mesothelial cells used to be cuboidal in shape, these stomas were high in number. Few stoma are present in other portion of the parietal pleura also. The distribution of stomas is similar to the distribution of particulate matter injected into the pleural surface. So like it is same. The lymphatic vessels in the parietal pleura have many branches. Some submesothelial branches have dilated lymphatic space called as lacunae. Stoma are found only over the lacunae. At the stoma, the mesothelial cells with their microvilli are in continuity with the endothelial cells of the lymphatic vessels. When RBC and carbon particle are injected into the pleural space, they collect around the stomach and the lacuna and the lymphatic vessels. Therefore, these stomas with their associated lacunae and lymphatic vessels are thought to be main pathway of the elimination of particulate matter from the pleural space. Very, very important. So this is very important. Like why stomas, lacunas, and these lymphatics are important. So they are telling if we put anything in the pleural space, they used to get out by this way only. Occasionally, macrophage can be visible. Occasionally, macrophage can be visible emerging from the lymphatic stoma and entering the pleural cavity. The stoma were usually round or oval in shape and approximately 6.2 micrometer in diameter. The stoma were not present in the visceral pleura or the parietal pleura on the chest wall. Most stoma were quite deep, forming channels that seemed to connect the pleural cavity with the underlying lymphatic lacuna. Then they are talking about the visceral pleura. Visceral pleura is abundantly endowed with lymphatic vessels. These lymphatics form a plexus of intercommunicating vessels that run over the surface of lung toward the hilum and also penetrate the lung to join the bronchial lymph vessel by passing through the interlobar septa. Although lymph may flow in either direction, all lymph from the visceral pleura eventually reaches to the lung root, either by penetrating the lung or by flowing on the surface of lung. So finally, it used to like if this is a lung, then either by like along the surface it used to come like this, or like by penetrating it used to come like this. So finally, it used to reach at the root of the lung. The larger lymphatic vessels in the visceral pleura are equipped with one-way valve directing flow. So they are telling wherever larger lymphatic vessels are there in the visceral pleura, they are equipped with one-way valves directing flow toward the hilum of the lung. No stoma are seen in the visceral pleura. Very, very important. So stomas are there. There is no stoma in the visceral pleura. And the lymphatic vessels of the visceral pleura are separated from the mesothelial cells by a layer of connective tissue. Okay, so these lymphatic vessels are separate from the mesothelial cells by the layer of connective tissue. The lack of stroma in the visceral pleura explain the observation that particulate matter injected in the pleural space is removed through the parietal pleura. Okay, and fluid from the pleural space does not enter in the lymphatics in the visceral pleura in the humans. Now comes Kemp-Myers foci. Kemp-Meyer foci, very very important. So let's discuss what is Kemp-Myers foci. Kemp-Meyer described small milky spots, very very important, in the dorsal and the caudal portion of the mediastinum in the rat and humans. So Kemp-Meyer foci are like small milky spots in the dorsal and caudal portion of mediastinum. Microscopically, the foci are aggregate of these foci are aggregate of lymphocytes, histiocytes, plasma cells, and other mononuclear cells around the central lymphatics and vascular vessels. It has been suggested that black spot in the patient with parietal anthracosis correspond to these Kemp-Myers foci, and that the distribution of asbestos fiber in the pleura is also concentrated in these foci. Very, very important. It has been hypothesized that high concentration of asbestos in these foci lead to development of pleural plaques and mesothelioma. However, the occurrence of pleural plaque is not related to location of black spot. Now, what is the innervation of pleura? Sensory nerve ending are present in the costal and diaphragmatic parietal pleura. Very, very important. So it is present in costal and diaphragmatic parietal pleura. The intercostal nerve supply the costal pleura and the peripheral part of diaphragmatic pleura. So like intercostal nerve used to supply both peripheral part of diaphragmatic pleura and the costal pleura. When either of these areas is stimulated, pain is perceived in adjacent chest wall. Very important. In contrast, the central portion of diaphragm is innervated by the phrenic nerve. Very, very important. So the central portion of the diaphragm, like if diaphragm having like this kind of appearance, then this periphery part is supplied by this like intercostal nerves. So and like this central portion is supplied by the phrenic nerve, and they are telling the stimulation of this pleura causes the pain which is perceived in ipsilateral shoulder. Very very important, very very important. If patient is having pain in ipsilateral shoulder, then you should suspect like there is lesion in central portion of the diaphragm. The visceral pleura contain no pain fiber, very very important, and may be manipulated without causing unpleasant sensation. So we can manipulate visceral pleura without causing any unpleasant sensation. Therefore, the presence of pleuritic chest pain indicate inflammation, irritation of the parietal pleura only. However, the visceral pleura does not have sensory receptors. Okay, they are telling like visceral pleura used to have sensory receptors, but they do not have pain receptors. And they are telling like visceral pleura have sensory receptors closely related to elastic fiber. The functional role of these receptors is not clear yet. So this was about the anatomy of this pleura and pleural space.